In this video, I want to talk about the technical aspects of placement of a spinal cord stimulator, both the trial and the permanent placement, to hopefully help you understand what you would be going through if you were going to undergo a trial and or a permanent stimulator placement. So spinal cord stimulation can be indicated for complex regional pain syndrome, post-laminectomy syndrome, which just means that patients have had a surgery and they still have pain and additional surgery is not thought to be helpful. We don't always know if a stimulator is going to be helpful for a patient. And fortunately, the stimulator can be trialed or tested first before committing you to placement of a permanent implant. The stimulator trial is typically done with the patient awake so that the stimulation can be felt during the procedure and the location of optimal stimulation can be identified. Most of the stimulator trials, in fact almost all of the time, they're done through a needle. And it's a stab incision, and then the needle is placed into the spine, and then through that needle the electrode is advanced up the spinal canal. And it's placed near the spinal cord, but actually outside of the covering of the spinal cord. So the electrode is actually not necessarily right up against the spinal cord, but is in the epidural space. If you think about a woman that's had as having labor and the anesthesiologist does an epidural, they're injecting medication into the epidural space. This is kind of like that, only they're putting in a needle and a wire into the epidural space that delivers electricity to the spinal cord. The patient will respond to the spinal cord stimulator rep as to whether or not they feel the stimulation and if it's covering the area of the pain during the trial. And it's important to communicate with the team in the room during the trial so that they can identify where the optimal place is for the electrode placement. Once the electrode is in place, the leads are coming out of the skin and they're taped to the skin and then connected to a power source that's external to the body. Now, that situation occurs for the duration of the trial, so 4 to 5 days typically. And the patient reports how they are feeling during the trial with different programs, and the determination is made during the trial, basically, if spinal cord stimulation is likely to help or not. Once the trial is over, the leads are removed. I don't do the trials, but sometimes patients are sent to me for consideration of a permanent implant. If a trial is successful and a permanent implant is wanted to be placed, then sometimes we will put that in, or other times the pain doctor will place them. The difference between the trial and the permanent is really the battery. So the leads are placed the same way in most cases, and then they're tunneled to a separate incision and a pocket where a battery is and connected to a battery under the skin. The permanent placement of the stimulator can be done awake, but we usually do them asleep so the patient is comfortable and we already know the optimal target and we can check that under X-ray. We put the leads in, connect them to the battery. In some cases, if the trial was difficult or the patient has some scoliosis or maybe a lot of prior surgery, the permanent implant can be placed in surgically, and this is a paddle lead. The difference between a paddle lead and a percutaneous lead is the percutaneous lead is placed through a needle and it's a wire. The paddle lead is actually placed through an incision and removal of the bone and then placed directly over the spinal cord and is a larger lead. It's more invasive to put in a paddle lead. I usually reserve the paddle lead placement, again, in situations where we think we may have difficulty putting in a percutaneous lead. Again, in both cases, the lead is connected to a battery. One risk is that the needle being used to put the lead in causes a spinal fluid leak because it went in a little bit too far. That risk is very low, but it can happen. And if it does, the leak will usually seal off over time. Another risk, and it's probably the one I worry about the most, is infection. So it's important to not have diabetes that's out of control and to have good aseptic or surgical technique during the procedure. We usually give a dose of antibiotics at the time of surgery. I typically don't do antibiotics after surgery, but one risk is infection, and if the system becomes infected, it needs to be removed. One final thing to consider is that the trial and the permanent implant may not have exactly the same results. Sometimes the patients don't seem to have a great trial, but the permanent implant isn't as successful. I think one reason for that is they're hoping the trial's helpful. When the permanent implant is placed, maybe the patient is expecting it to be helpful. The final issue is that sometimes the lead can migrate, meaning that the lead is placed, everything's in good position, and then at some point after surgery, the lead moves. This situation is uncommon and is much more common, though, with percutaneous placement of the lead. If this happens, it can be adjusted, or sometimes we have to go back in and place a surgical implant. Spinal cord stimulation is a good solution or a part of the management strategy for patients with complex regional pain syndrome, post-laminectomy syndrome, and other types of pain. And hopefully this is helpful in helping you understand the technical aspects of placement of the trial leads and also the permanent system.